Dr. Noseworthy is an associate professor of medicine and a consultant at the Mayo Clinic in Rochester. He obtained his medical degree at the University of Toronto, Faculty of Medicine, and did his training in internal medicine, chief residency, cardiology fellowship, and EP training at Massachusetts General Hospital, and thereafter joined the faculty at Mayo Clinic in Rochester. At Mayo, Dr. Noseworthy's clinical and research interests focus on the pathophysiology and management of atrial and ventricular arrhythmias, and in particular, the genetic determinants of ventricular arrhythmias and non-invasive means for arrhythmia risk stratification and health outcomes in patients undergoing cardiac ablation. His recent work has focused on the application of artificial intelligence approaches to ECG interpretation, and his group recently completed a large pragmatic RCT that I'm sure we will hear about today. Beyond all of those fantastic accomplishments, Peter is an old friend, a colleague, and a teacher. He was my chief resident at MGH and an EP fellow when I was a general cardiology fellow. So a lot of what I know about EKGs, I learned from Peter, I think, as an intern, but please do not blame him for any gaps in my knowledge. That is solely and completely my fault. He's a great teacher, and I really look forward to his talk today. Thank you so much, Peter.
Thanks, Oyuri. Thanks for the kind introduction and the opportunity to speak with you all today. I've had the chance to work with a number of people at Yale over the past couple of years, so I feel a strong connection to Yale, and it's a real honor to be able to give grand rounds, especially amongst the incredible faculty that you draw on for your grand round. So I hope that I'll have something interesting to tell you about today. I'm excited to talk to you about it. So as Oyuri said, I wear a number of hats at Mayo. I do ablations. I've done a bunch of sort of observational big data analytic type work, but I also have a role as a director of our ECG and physiologic monitoring lab, which when I was asked to run that group, it sounded like a mundane task. Basically, that's the core facility that reads all the ECGs, Holter data, and so forth. But in talking to my chair, Paul Friedman, came to the realization that we were sitting on a mountain of well-archived, well-annotated, meticulously labeled physiologic data, namely ECG data. Each ECG is obtained in exactly the same protocol, and then we've been using the same sort of IT systems to read and archive these ECGs for decades. So that gave us an incredible database, essentially, for which to develop some new technologies and try to apply them to AI. And we were just starting to hire some computer scientists into our group. And this seemed like an ideal test case or sort of sandbox to learn about how we might be able to apply some AI technologies to medicine. And it's been really exciting for me. This is not something that I anticipated doing. I don't have a background in computer science or AI in any way, but as a clinician partner, we've been able to build out a very interesting, in my opinion, a body of work around this. And we're really transforming the way we think about ECG data at Mayo. And I'd like to share that with you today. So the work that I do in general is supported by a number of different grants. Some of the AI work has been, we filed intellectual property on it. A few of the things have been licensed to various companies, and we do have a number of patents. So just keep that in mind as I present this. To be frank, we haven't made a penny from any of this, and we're not necessarily trying to, but it's new ideas, and it is being protected by Mayo Clinic. So take that as my main disclosure. The ECG has been around for a long time, and it really has been very static. It's really amazing that a technology as old as the ECG has had the staying power it has had in cardiology. Really, those of you who have been in practice for a few decades have noticed that we basically are using the ECG in the same way. But I think that's about to change. And not that the old way of reading an ECG is going to be obsolete, but I think we're bringing new life and sort of breathing new life into this old technology. So let me just show you an example. Here's an ECG from a 39-year-old man. This was actually my ECG. It was a year or two ago. I'm now a little older than that, but it showed normal sinus rhythm and sinus arrhythmia. That's great, but this is hardly an informative ECG. And I think you'd look at this and say it looks more or less normal. But taking the AI technologies that we've developed and turning them towards this ECG, we can see that it is able to discern things that even an expert cardiologist is not able to. So it could guess that my age was 37, which I think is quite remarkable. Those of us who read a lot of ECGs get a sense of maybe this is somebody with a lot of comorbidities and advanced heart disease, but it's hard to pinpoint an age. It could tell that I was male with 98% probability. It estimated my ejection fraction at 58%. And it doesn't think I have hypertrophic cardiomyopathy or I'm at very low risk of undiagnosed atrial fibrillation. So taking these models and turning it onto my ECG, it turns the ECG into something that is reassuring as normal, but relatively binary as normal or abnormal, and turns it into something that's richly informative. Now, thankfully, it didn't diagnose me with any major medical conditions, but there are many other patients in whom it's been more useful. Here's another young man, 35. He presented for evaluation after his sister had died suddenly. And again, our ECG lab read this as a normal ECG. Maybe the R wave progression is a bit poor, but it was read as normal. And the AI turned to this ECG, gave it a 76% probability of having a low ejection fraction. And indeed, when we got an echocardiogram, his EF was confirmed at 18%, completely asymptomatic. He was then genotyped and his family went on to be diagnosed with a familial cardiomyopathy that likely underlied his sister's sudden cardiac death. So had his sister been screened perhaps with an AI ECG, or had we had ways to deliver this kind of care more broadly, perhaps this could have been picked up at an earlier stage and made a material difference in this family's care. So taking a step back for a moment, when we apply AI technologies to ECG interpretation, there are really two goals that we're trying to accomplish. One is to streamline human capability. Basically, can AI read an ECG the way a human can? And if it could tell us what we can usually discern from an ECG, ischemia, rhythm, et cetera, then we could use that as a first pass interpretation. Clearly, we really think we could probably beat the little computer generated report that comes up at the top of an ECG. This would allow us to triage workflow, maybe flag potentially important ECGs. Since we have centralized services for ECG reading at Mayo, this would allow us to scale our work and perhaps read ECGs for other institutions and things. So that's the sort of typical application of AI, doing what a human can do, just doing it faster and more reproducible and helping aid human workflow. But the second is what I think is most interesting, and that's when the AI can see beyond human capability. And I think I've basically demonstrated that already. Clearly, we can't tell the ejection fraction, the age, the sex, the likelihood of disease X, Y, and Z with ease from an ECG, but we really can bring new value to an ECG by applying AI. So just two slides on the first thing, which is basically comprehensive ECG interpretation, and then I'll go back to the examples of seeing beyond human capabilities. So this really seemed like it would be the easiest task. Reading an ECG should be pretty straightforward. We already have algorithms to do it. We thought we'd be able to beat it fairly easily. Because we have nicely archived ECGs and we use the same language in the interpretation and have done so for decades, we were able to train separate convolutional neural networks to pick up the ECG signature for each of the 420 statements on an ECG. That was good, but then we ended up spitting out dozens of codes per ECG, and it wasn't terribly helpful because it was much too sensitive. We then looked at ways to predict codes in combination, and there it sort of learns the association that if there's LVH, there's more likely to be left atrial enlargement, there's more likely to be strain pattern and so forth, and some of those patterns started to emerge. And the last thing that was really the game changer for us is we put a transformer step in, and that's a step in a network that spits out a sentence that looks like a human generated phrase, and it basically translates it to the language that we use in ECG interpretation. And with that technology, we were able to generate an algorithm that actually does pretty well for reading a comprehensive ECG. And we've compared this in sort of a black box Turing test fashion to the Marquette read using the GE 12SL software that comes off the device, our AI read, and then our ECG lab finalized read, which is signed off by cardiologists. And what we found is that we get the primary diagnosis right 94% of the time, and then every diagnosis on the ECG correct and in the right order in about 85% of the time. So it's good, but it's not great. And we need to continue to work on this. And this has really proven to be one of the more challenging tasks. But what's most interesting to me is being able to see beyond human capabilities. And those are some of those things that I showed you at the beginning with those introductory slides. And I'm going to show you 3 examples, how we developed them and how we're applying them. And then in the latter part of the talk, I'll mention some randomized trials and things we're doing to try to test these algorithms more rigorously and prospectively. So first, detection of low ejection fraction. Of course, we don't tend to use an ECG to diagnose low EF. We can tell if somebody has heart disease, but we don't usually use it as a test of low ejection fraction. But leveraging the fact that we had hundreds of thousands of ECGs in patients with paired concomitant echocardiography, we could train a network using to pick up an electrocardiographic signature that correlates with a low ejection fraction by echocardiogram. And we basically create a derivation test set, and then we test it on a separate reserved set of untouched ECGs and echocardiograms. And the AUC here was 0.93, which is really an excellent AUC. Most of you are aware of this, but the AUC for tests that we use all the time in routine clinical practice tends to be between 0.65 and 0.75. If you think about the CHADS-VASc score or the AUC of a mammogram or a pap smear or any of these diagnostic tests that we rely on all the time. So the test characteristics, at least in our data set, are very good for this test, and we've gone on to validate it in other populations with collaborators around the country and around the world. We've validated in groups in Brazil, in Scotland, South Korea, various other populations, and we're looking for collaborators across the US to continue to do this. But suffice it to say, we have growing confidence that the model performs quite well. Our colleagues throughout the Mayo Clinic system have then begun to test this algorithm in various applications. We have a group in Mayo Clinic, Florida, who are interested in testing it in the emergency department among patients who are presenting to the emergency department with dyspnea. And their question was, can we tell just based on the intake ECG whether their dyspnea was related to heart failure or pneumonia or some other non-cardiac cause, asthma, whatever it might be? And then how did it compare to assessment of natriuretic peptides? And here in this population, the AUC was 0.89, also very good. So indicating that perhaps that triage ECG could trigger them to think about heart failure early, maybe get an echo in the emergency department, get the patient diuresed and get them the care they need. Our colleagues in the critical care unit were interested in how it correlated amongst patients who had who are critically ill, admitted with myocardial infarction, end-stage heart failure, whatever it might be that put them in the CCU. And they were able to demonstrate that it had good test characteristics, even in that very sick population. But even more importantly, is it seemed to be a marker for in-hospital mortality. And the higher the score, the higher risk these patients were. So not only diagnostic, but also prognostic. As we should be with all AI, and we're increasingly realizing this, we have to be very cognizant of the fact that if there are biases in the way we diagnose low ejection fraction or in the way we screen for it, then if we use our existing data to train new algorithms, we run the risk of promoting and potentiating these kinds of biases in our healthcare system. So although we don't have a terribly diverse population at Mayo Clinic, we were able to draw from a very large population to do well-powered subgroup analyses by various racial and ethnic groups, and demonstrated remarkably consistent AUC across the range of subgroups here, with AUCs about 0.93 to 0.94 in almost every subgroup, giving us some confidence that it should work relatively well across broad populations. Now, the model performance was really great. It was exciting to see an AUC of 0.93. I've been doing predictive analytic work using big data sources for a long time, and we never were able to achieve numbers like that. So we thought, what if we were to add just a couple key variables? What if we added sex and age to our model? Would it improve the model performance? And we were amazed to see that to 3 decimal points, it made absolutely no difference. And that was a bit of a head scratcher for me and for some of my other colleagues. But the data scientists in the group said the reason this is that the model can probably already discern age and sex from the ECG. You're not giving it any additional information by giving it these additional data, structured data points. So we wanted to prove that. So we trained separate models to look at sex and age, and we're able to demonstrate that it's exceptionally good for picking up the sex of a patient based on the ECG. So good, in fact, that we use this as sort of an internal positive control now for ECG quality, for the application of AI and the quality of doing that. If it gets the sex wrong, the other models tend not to work very well, and it may mean that there's lead misplacement or there's a noisy signal, baseline artifact, something like that. And then the correlation is less tight for age, but still pretty good. And this brought up a whole host of questions. Is it telling us something about chronological age, or is it telling us something about physiologic age? And does this actually have implications for prognostication around the perioperative period? What about overall survival? And there are other groups at Mayo that are working on pursuing these questions, and we're having some very interesting findings. Just after we developed the age algorithm, one of my colleagues, Suraj Kappa, did a case review of cases where it seemed to fail, because we wanted to understand what it was looking at. And this was a particularly dramatic one. Patient looked about 20 years older than his stated age and was aging at a rapid rate, and then overnight appeared to get considerably younger. And we dug into the chart, and this was actually the date of his heart transplant. And he got a heart from a younger man, and indeed that was reflected on his ECG. So anecdotal, but just kind of fun to see that proof of concept that it's telling us something about the age of that heart. Second example I'll talk about is hypertrophic cardiomyopathy. As you're all well aware, hypertrophic cardiomyopathy has a clearly associated with an abnormal ECG, but there are many different patterns that we can see in hypertrophic cardiomyopathy, and there's not one pathognomonic signature that we can use. And because of that, it's very controversial about whether we should be screening for HCM with ECG in athletes, for example. And most of us don't do it, just because our ability to pick up HCM is not powerful enough to warrant widespread screening. But we do have a very large HCM practice at Mayo Clinic, and we have a group of several thousand well-characterized, many of whom are genotype proven HCM cases. And then we're able to draw age and sex match controls from our greater ECG database, and then separate it into training, validation, and testing data sets, as we tend to do. And the model performance for HCM was exceptionally good with an AUC of about 0.96 in our testing data set. Furthermore, you see that there's very good separation of the cases and controls based on the model output. So it doesn't tend to hedge. It tends to say this looks like HCM or not, based on the way we've trained the model. We looked across a range of subgroups, and you can see that it works equally well in men and women. It works particularly well in younger patients, and these are the patients who we'd like to diagnose HCM in. They're at higher risk of sudden cardiac death, and they have more years of risk ahead. And really fascinating to me is it worked equally well in patients who had left ventricular hypertrophy on the ECG and those who had a normal ECG. So about 10% of people with HCM actually have a normal ECG, and it was still able to discern the pattern. And it worked well whether or not there was a sarcomeric mutation. Shortly after developing this model, I was rotating on our clinical service, and I was asked to see a patient by our cardiac surgeons who were performing a septal myectomy in a young woman with really severe HCM with massive septal hypertrophy. And this was her pre-op ECG on the day that I saw her. All you can see is this sort of T-wave abnormality in the right precordial leads. It's really isolated to V1 and V2. Again, our ECG lab called this a normal variant, and sometimes you see sort of these juvenile patterns, but it was not picked up by our cardiologist as an HCM ECG. And I wanted to see what the model thought. And indeed, the model gave her a 72% probability of HCM. If you think about the baseline prevalence, or being 1 in 200 to 1 in 500, that would be the average model output for an average ECG. So the diagnostic odds ratio here is exceptionally high in alerting us that this may be a patient with HCM. So I found that to be very reassuring, that even in the cases that appear to slip through our fingers through in the ECG lab could be found by this kind of model. I also found it interesting that the next day that I saw her, she had a post-op ECG done. She'd had her septal myectomy, and she had a bit of pericarditis, and she had some fractionation of the QRS complex. And really, her ECG now looks a little bit more abnormal than it did at baseline. But to the AI model, it looked less like HCM. So her probability went from 75% to 2%. And even though the ECG was more abnormal, it was less characteristic of HCM. So something about taking out that abnormal myocardium in the septum seemed to change the ECG in a way that was discernible by the model. So again, anecdotal, but it's always nice to bring this back to individual patients and think about how this can be applied. The last model I'll discuss today is our model for atrial fibrillation. The problem, as everybody on the call is well aware, is that AFib can be fleeting, it can be asymptomatic, can be hard to diagnose, it has serious consequences. It may drive the risk of stroke in people with unrecognized atrial fibrillation. If we think somebody might have AFib, we go as far sometimes as implanting a link. This is an expensive and invasive procedure, well, not terribly dangerous. It does drive up healthcare costs, and there's got to be a better way to stratify the population and figure out who's at risk of AFib based on their normal sinus rhythm ECG. So taking the same principle, we created a pairwise comparison and a binary classifier using a convolutional neural network trained to pick up the signature of AF risk on the normal sinus rhythm ECG, essentially with a population who had episodes of atrial fibrillation, but had periods of sinus rhythm that we could use as a reference point, and then the pure sinus rhythm cohort. The AUC here for a single ECG is a 0.87. And if you use multiple ECGs, it improves to about 0.9. So good model performance, but a more challenging task than diagnosing hypertrophic cardiomyopathy. We then looked in a prospective data set at Mayo. There's a study called the Mayo Clinic Study of Aging, which is a study put together by our neurology colleagues to look at dementia in the population. But the patients are very well characterized with MRI, a serial ECG, and so forth, analogous to the Framingham cohort, but within Olmsted County. And what you can see here is that the model output had a graded relationship to the risk of incident atrial fibrillation. And once it got to about a threshold of 0.5, the cumulative incidence of AFib was about 25% at 2 years and 50% at 10 years. And of course, you could draw the line in the sand anywhere in terms of that model output to favor sensitivity or specificity of the model, depending on the application that you're interested in. Not only does it appear to predict incident AFib, the very high end of the model output also correlated with stroke in this population. I think giving us some preliminary observational type data to suggest that we might be able to use this as a way to segment the population in terms of AF and stroke risk. So I'll go back now, another anecdotal case. One of our colleagues in neurology heard about this model. He was actually involved in deriving it with us. And he saw a patient in clinic that he had been following for over a decade. She had been cared for at Mayo since the 1990s. And in 2015, she suffered a stroke. And at that time, he did extended monitoring, couldn't diagnose any atrial fibrillation, and she was in sinus rhythm in the hospital and on ECG. So couldn't justify anticoagulation. She went on dual antiplatelet therapy for a period. And then he did see her for several years until, unfortunately, she was readmitted in late 2019 with a recurrent stroke. At that time, she was still in normal sinus rhythm. He repeated monitoring and didn't see any atrial fibrillation. But he wanted to know whether she was at risk. About 2 weeks after that, she was admitted with atrial flutter with rapid ventricular rates, confirming his suspicion that there was probably subclinical atrial fibrillation that had eluded diagnosis. But if we look back at her model output for the AF model, our threshold for a positive test is here. 10 years, 12 years before her first stroke, she actually was starting to exceed the model output, at which point we think she's at higher risk. So it's possible she could have undergone some prolonged screening at this time and maybe made an earlier diagnosis, or maybe the risk was here was high enough that in the setting of a ESIS or cryptogenic stroke, he could have justified anticoagulation. All these things will, of course, need to be tested, and that's what we're working on next. But at least we think these models may help inform our decision making. So late last year, there was a dedicated issue in Nature Medicine, and the editorial board wrote that delivering on the potential of AI will require testing of these interventions in randomized trials and reporting these results in standardized and transparent fashion. Basically, a call to the field to say, don't just create these algorithms in your own data sets and show us nice AUCs, test them prospectively, hold them to the same standard that we do for any diagnostic or therapeutic intervention. And we've been trying to do just that, and we've completed now one clinical trial, which was the EAGLE trial, looking at the low ejection fraction algorithm, and we're currently testing our atrial fibrillation algorithm in the follow-up, which is called BEAGLE, and I'll go through each of these in a little bit of detail. So EAGLE was a cluster randomized pragmatic clinical trial that we executed within our Mayo Clinic healthcare system in the upper Midwest across Iowa, Wisconsin, and Minnesota. Here, primary care is delivered by care teams. So we were able to cluster randomize care teams to either receive the result of the AI or to undergo usual care. And we deployed the model through Epic. We then looked at how often we were diagnosing new low ejection fraction. We looked at treatment patterns, whether people were treated appropriately with medications for low ejection fraction, and we did a qualitative assessment. So here's a de-identified view of an Epic window. If they were reviewing the ECGs in a patient who was in this trial, the model output was reported as a PDF within Epic, and they also got a reminder email to tell them that the test was positive and that they may consider doing an echocardiogram. Over 5 or 6 months, we enrolled about 32,000 patients through our Mayo Clinic primary care health system. About 6% of patients had a positive ECG, and then clinicians were allowed to either obtain an echocardiogram or not at their discretion. What we see is that about 50% of patients in this trial were actually cared for in a rural setting. So this was not, we're not testing this in specialty cardiology clinics, we're testing this in the community at large. And about 50% of the ECGs were obtained in the outpatient clinic. ECGs were obtained for a variety of indications, and only less than 5% were ordered for shortness of breath. So we don't think these ECGs were done to look for low ejection fraction. These were done, pre-op ECGs or screening for, palpitations, whatever it might be. But clinicians were not necessarily looking for low ejection fraction. What we saw, and we were reassured to see that we increased the diagnosis of low ejection fraction by about 30% by deploying this model. So it's still relatively uncommon in people who don't have any suspicion or symptoms of low ejection fraction, but the diagnosis rate went from 1.6% to 2.1% among people undergoing echocardiograms. But we didn't increase the echocardiograms by much overall. So in the overall population, it was no significant increase in the rate of echocardiography. And amongst people with low ejection fraction, it only increased by 12%. So we made a relatively small increase in echo utilization in only 6% of the population, but we're able to increase the diagnosis of previously unrecognized low ejection fraction. It performed well across a wide range of subgroups, but particularly in the outpatient setting. I think that within the hospital, there's ready access to echocardiography, and people in the hospital are more likely to be well characterized. So the additional diagnostic yield is less dramatic in this setting. But it tells us something about maybe it makes sense to deploy these kind of algorithms in the outpatient clinic setting, more so than in the hospital setting. Among people with newly diagnosed low ejection fraction, the vast majority were treated with ACE inhibitors or beta blockers, indicating that not only were we diagnosing more patients, but we were getting them on appropriate treatment. So trying now to put this in a bit of context, for every 1,000 patients screened with this AI model, 6% or 60 patients would have been flagged as potentially having low ejection fraction. Among those, we would increase the number of echoes by about 7 echoes out of the total 60 potential candidates. And with this, we would have made a new diagnosis of about 5 new cases of low ejection fraction for every 1,000 patients screened. So that may not seem like a lot, but if you think at a big health system like Yale or Mayo Clinic, we do around 300,000 ECGs enterprise-wide per year. So taking this by 300, we could potentially diagnose 1,000, maybe 2,000 new patients with previously unrecognized low ejection fraction. The next model that we wanted to test was our screening for atrial fibrillation. And as I think most of you are aware, current recommendations are not to do ECG or Holter monitor screening for atrial fibrillation. And that's because there are a lot of gaps in knowledge along this continuum. We know we can probably pick up people, but we don't know that this is cost effective. We don't know that if we were to diagnose atrial fibrillation in somebody who's completely asymptomatic, that treatment carries the same benefit that it does in symptomatic patients or patients who have come to clinical attention. And until each of these things is addressed with further study, we're unlikely to see recommendations for widespread screening. So we want to try to build out that knowledge base. The second study is called BEAGLE, and the idea here is that we can enroll patients in batches. So what we've done is we're running an NLP algorithm on existing health records at Mayo Clinic to identify patients who, if we were to diagnose atrial fibrillation, they would be at high enough risk to warrant anticoagulation, but they're not such high risk of bleeding that they would have any contraindication of anticoagulation. So trying to find those patients who are in a sweet spot where we want to diagnose atrial fibrillation. And we're running that algorithm on basically all Mayo Clinic patients. In parallel, we're running the AI ECG algorithm on anybody who's had an ECG at Mayo Clinic in the past year. And if they're flagged as somebody who might have AFib, and the NLP has told us that if they do have AFib, we would want to anticoagulate them, we're sending them a message through our patient portal, and they can do the consent process through their phone. They don't have to come to Mayo. They don't have to talk to a study coordinator. It's all done remotely. And we've been enrolling patients from across the country quite efficiently and at low cost with this approach. And it's been a very interesting exercise. If they're enrolled, they don't have to leave their house. We send them in the mail a kit for cardiac monitoring. We're sending them this leaded device that connects to a transponder that has it sends to us the data via a cellular connection. So if they're diagnosed with AFib, we know it immediately, and I get on the phone and I call them and let them know. So I'll just give you a case example. There was a retired Mayo Clinic doc who we enrolled in this study. Shortly after sending him the device, he went into atrial fibrillation, and we were able to diagnose it and get him on anticoagulation. And then looking back at his ECGs over the years, here's the model output. So as far back as 1993, he actually had ECGs which were flagging as positive for atrial fibrillation risk, but every one of these ECGs demonstrated normal sinus rhythm. So it wasn't until the AI looked at his ECG and we were able to send him a device that he was actually diagnosed. And there was another case, just yesterday actually, Casey Ross at STAT did a story on this study and interviewed one of the patients who's enrolled. This was a different patient who was also cared for at Mayo for a long period of time, many ECGs, always normal sinus rhythm, but he was diagnosed with atrial fibrillation in this study and was initiated on anticoagulation. This article gives a relatively balanced take on what the value is going to be of this kind of approach and how scalable and so forth. But it's worth a read, I think, for context. So we also want to try to get these technologies into the hands of patients and clinicians, and we've created some IT infrastructure to do this. So here's a screen grab of my EPIC chart. And if you go into my chart under cardiology, you'll see this tab called AI ECG dashboard. And if you click on that, it opens up this separate viewer. And here it'll show the ECG, it'll show the ECG interpretation, but it also shows each of our AI models for every ECG over time graphed across here, and then the models in a quantitative sense in this table. And this is now run in real time for all ECGs done at Mayo Clinic, and it's available to all clinicians. And these are not FDA approved. We don't want them to be used for clinical purposes, but people are starting to get some experience on how this interface works. They're using it to do clinical trials and observational studies like the ones I showed early on in the emergency department, in the CCU, et cetera. And here's an example of the dashboard output for that patient who had cryptogenic stroke, and it allows clinicians to see what the models are doing over time. This was a cool patient who had a heart transplant. He had low ejection fraction in the early 2000s, got a transplant, and his EF, of course, normalized, was doing very well until late 2019. At this point, he came back in and was found to have rejection of his transplanted organ. And just think about how many biopsies we do in the transplant population. I wonder, and we're trying to test these kinds of hypotheses, but whether we could train AI algorithms or use the existing low EF algorithm as a surrogate for biopsy, perhaps, or maybe alternate the biopsies every other time and try to reduce healthcare utilization in some of these patients. And we're also trying to get these technologies in the hands of clinicians in some novel ways. This is an example where Mayo Clinic, not me personally, but Mayo has licensed one of these technologies, the low ejection fraction algorithm, to a company that makes a stethoscope. This stethoscope has two metal plates that record a single lead ECG, just like an AliveCor device, and then it has a microphone that creates a sonocardiogram. And the original idea that this company had was just to be able to record heart sounds, and then you can pass the stethoscope around on rounds and listen to murmurs and use it as a teaching tool. But because they were also recording the single lead ECG, we had the hypothesis that we could deploy an AI algorithm for low ejection fraction detection on the stethoscope, essentially turning the stethoscope from a device used to listen to heart sounds to one that's used to record and teach heart sounds to one that's used to deploy AI ECG algorithms at the point of care. And I think this kind of technology, whether this will pan out, I'm not sure, but it's an exciting way to sort of get these algorithms into the hands of clinicians and increase the yield of physical examination and so forth. And we now have algorithms for detection of valvular heart disease and things like that. And there's a lot of interest in how to deploy these algorithms. So I would say that we're all in agreement that in order to meet the needs of patients, we need large multidisciplinary teams, each bringing their own expertise to the point of care. And we deliver the best care we can when we have integrated approaches that leverages expertise from cardiology, intensive care, primary care, surgery, nursing, support staff, all working together. But the past couple of years at Mayo, what we've really seen is that there's also a role for the AI engineer. And this work would not have been possible without bringing a team of engineers into sort of the circle of patient care. I now interact with our engineering team almost as much as I do my colleagues in cardiology on a nearly daily basis. They've helped us look at old problems with new eyes and have greatly, I think, increased our ability to unlock some of this data that are essentially hidden in plain sight, and it's been very exciting to me. So I think that we've demonstrated that AI has clinical utility and that it can be integrated into our current workflow. We're now using this in an integrated way in EPIC, and it's been very valuable. We can predict and detect disease as demonstrated in these clinical trials. It's massively scalable through electronic health records or even novel devices like AliveCor and these different form factors. And I think that this is a way that we're starting to try to innovate and drive changes to the practice of medicine at Mayo Clinic. So I'd be happy to answer some questions at this point. Thank you very much.
Peter, thank you so very much. That was excellent and just amazing. I'm sure there are a ton of questions. Dr. Lampert, I see you over there, so I'll let you get the first word question in here.
Thank you, Ayeri. Peter, that was really fascinating, very exciting stuff. I have two questions for you. The first is about what you described most recently about the AliveCor-like device. I mean, we, think about the 12 leads of an ECG as combining, providing complementary information from all 12 leads. So have you looked at the relative sensitivity and specificity of a single lead recording?
Yes.
That's question one, and I'll ask you question two as well. As the person who runs our ECG reading, do you think the AI will ever replace us? I ask with ambivalence.
Yeah, there is some ambivalence there. We like to read ECGs, we just don't like to read hundreds of them in an afternoon. So the first question is, how do these models perform in a single lead? And that's something that we've tested. So far, all of the models that we've derived have used all 12 leads in the initial derivation and testing. But then we tend to take the same model and look at how it performs lead by lead. And we're most interested in how it performs in lead one, because most form factors in Apple Watch and a AliveCor device are most similar to a lead one across the chest. And there's a little bit of a diminishment of the model performance, but it's still relatively good. So if the AUC was 0.93, it might go to 0.88 or 0.87 or something. So still good as a point of care test. And that's taking a model that was derived on 12 leads and applied to one. It may perform even better if we were to actually then do some subsequent refining of the model for a single lead application. And those are things that we're working on. Especially important for things like QT measurement from a single lead, because it would be nice to be able to measure the QT in ambulatory patients. You can think about drug loading, you can think about methadone or psychiatric medicines used in combination, which can have dangerous QT prolonging and potentiating effects. So I think 12 leads is better, but one lead is probably good for many applications. Do I think that we'll replace ECG readers? I don't think so. I think that these models are good for telling us the things that are readily discernible from an ECG, the rhythm, the patterns that we can call, but a really nuanced ECG interpretation from an experienced person in a way that, the ECGs that come across your desk, 1 in a million, there's never going to be a computer system, or it's hard for me to imagine that we're going to be able to do that anytime soon. And even the simple ECG interpretation, the very first part of my talk, I showed that right now we're only at 85%, even for the top line diagnosis. So I think it'll help streamline our workflow. At Mayo, what we do is the ECGs are read, there's a computer printout, it goes to our ECG techs. We have about 130 ECG techs who are reading these. And then it goes to a single ECG reader each day who overviews them. But that person now has to read 500 to 700 ECGs, sometimes more per day. So they're really signing off on the work that was done by our ECG techs. And if we could streamline that workflow with one more level of assurance, I think that work is more scalable. But that's how we do it at Mayo.
Thanks, Peter. Joe Akari had a question.
Yeah, Peter, thank you very much for a wonderful talk. That was some incredible work that you're doing. My question relates to AFib and our ability to identify those patients with AFib, because as you said, ultimately, this is a potentially very actionable measure that we're doing with anticoagulation, et cetera. And the questions regarding that are regarding silent atrial fibrillation, and because we know that our ability to detect AFib is really proportional to how aggressive we are in terms of trying to detect AFib. So a 30-day monitor may or may not detect atrial fibrillation. The second aspect of that is that we still don't know what burden of AFib really constitutes stroke risk. So how do you adjust for these unknowns is my first question. And a related second question is, for those patients who you are identifying at risk of AFib, and I may have missed this, but how much does your algorithm add on top of other clinical measures that put you at risk? So for example, you showed the patient who has kidney disease and who has diabetes. And those are, hypertension, et cetera. Those are potential measures that we clinically know put you at AFib. So how much is your algorithm adding on top of this?
Yeah, those are all excellent questions. So I'll take them sort of in reverse order. What does it add in addition to what we already know? So in the study for prospective AF, in the Mayo Clinic study for aging, we also looked at the CHARGE AF score, which integrates a variety of clinical risk factors. And it performed marginally better than the CHARGE AF score, but not dramatically better. And it improves the diagnostic yield in combination, but not dramatically. The advantage here is that it gives us all the same information as extracting all that clinical data and creating a model just with a single ECG. One of the big caveats to the AF model is that we trained it for concomitant AFib because we either had people who had AFib on one ECG and sinus rhythm on the other versus always in normal sinus rhythm. So it wasn't trained to look at incident atrial fibrillation. I think we need to do a fair amount of recalibrating and tuning of the model for that application. I also want to, I didn't present these data, but I should give a bit of a caveat to the AFib data because we were initially very excited about this, but we've subsequently applied it to a variety of different AF-related phenotypes, postoperative atrial fibrillation in various provoked states, and it doesn't perform very well for the prediction of post-op AFib or even the prediction of recurrent AFib amongst people with post-op AFib. So I think AFib is a really heterogeneous condition, and one AF model may not actually work well for all applications. You asked a question about how to pick it up once we've flagged people as potentially being at risk. In the Beagle study, we're using a 30-day monitor, and we're hoping to have a diagnostic yield of between 10 and maybe 20% in 30 days. But that doesn't mean that those other 80% of people won't have AFib at some point in their life. So it doesn't really solve that problem about how do we predict AFib that may be 5-10 years out. So there may have to be a system where people are continually reassessed. Your first question was about the threshold for atrial fibrillation burden at which anticoagulation is warranted. And that's a very key question. And I tried to allude to that when I showed the sort of spectrum of knowledge that's needed to justify population screening for atrial fibrillation. And we don't really know that AFib that's detected on a pacemaker or detected incidentally on a Holter carries the same prognostic implications as clinical atrial fibrillation. And as such, we don't really know at which threshold to anticoagulate. For device-detected AFib, there are the two main prospective studies ongoing, Artesia and NOAA, and hopefully those will tell us whether we need to anticoagulate for device-detected AFib and at what threshold. Is it 6 minutes? Is it 24 hours? And hopefully we'll have data in the next couple of years. For screen-detected AFib, it will require a dedicated study. So if Beagle is successful, and we can identify that we're able to pick up patients with atrial fibrillation in a 30-day event monitor, the next study will be a treatment study looking at prevention of cardioembolic stroke. That will need to be a large multi-center study in order to enroll enough patients at risk with screen-detected atrial fibrillation. So, Joe, I may come to you to see if you want to participate and collaborate down the road if we're successful in our first pilot.
It's always been great to collaborate with you, and we're always open. Thank you very much, Peter, for a great talk.
Yeah, likewise. It's been great working the last couple of years with you, Joe.
Thanks, Peter. We have a few questions in the chat. I'll take one from Erica Spatz, and then we'll have Dr. Velasquez. So Dr. Spatz says, this is terrific work. Can you talk about the potential for overdiagnosis? And she also asked if there are any variables that you think may explain the differences between normal age sex features in V1, V2, V3 in someone versus someone with high probability for HCM, like the case that you presented. So talk about the potential for overdiagnosis using this technology when people have their Apple Watches and your algorithm and it tells them everything that's wrong with their ECGs.
Yeah, right. I think there's an enormous potential for overdiagnosis. That article in STAT published yesterday highlighted that because one of the investigators actually did an ECG and it was positive for hypertrophic cardiomyopathy. And he went through echo and all of this and had 5 days of anxiety about the fact that he may have HCM and everything checked out. So sometimes it really hits home and we see it for ourselves. And we're not supposed to be using this for clinical use, but I still peek on my patients because I'm curious, and that's a dilemma that is new. What do we do with these information, especially when they're completely unanticipated? And we need to basically, this is new. We need to figure out what those guardrails are for how we apply these things in a way that is thoughtful and doesn't increase diagnostic testing. If you think about in the EAGLE study, even though we diagnosed a lot of new patients with low ejection fraction, at least 50% of the echoes that were done were probably normal. So the false positive rate was between 50 and 60%. That's pretty high, and you have to think about whether that's justified. We always have to be worried about introducing new technologies that ratchet up healthcare costs, because once you do it, it's hard to dial that back. And if you think about evaluating hypertrophic cardiomyopathy, if echo is not enough, you're talking about cardiac MRI and referral to specialists, and there's enormous potential for this to spiral out of control. The next question was about how do we, I read the next question as basically, what is ECG seeing and what abnormalities is it picking up and relating to these various phenotypes, HCM and age? And one of the difficulties is that it really is, at least a convolutional neural network in its current iteration, is a black box. We basically get a model output, but it's not telling us what on the ECG it's actually looking for. One of our engineers just finished his PhD, and it was all around trying to develop explainable AI for ECG. And I'll just briefly, it's a little beyond me, to be honest, but basically he created a system called a generative adversarial network, which is 2 neural networks that are trained against each other. And one reads the ECG and generates a model output. The other essentially creates a synthetic model output itself, an ECG. And they go back and forth until it creates a model that the other one can't tell from a real ECG. And if you tell it to look for a HCM ECG, as it iterates, it essentially makes a caricature of a hypertrophic cardiomyopathy ECG. And that tells you sort of what kinds of things is it looking at. The problem is it doesn't look much like an ECG. It's a very exaggerated ECG. People have done this for, what does a zebra look like to a convolutional neural network? And it looks like a bunch of stripes and a mane and the sign at the zoo and a bit of savanna. It doesn't look like a zebra. It's sort of essence of zebra. And that's the same problem with an ECG. There are attentional maps that you can do, or heat maps, essentially, to say which portion of the ECG is contributing most. And you can look at that on an ECG by ECG basis. And it's fascinating. Sometimes it's looking at the QRS, sometimes the PR, but it's all over. All of the ECG seems to be contributing, at least in some cases, to model performance.
I'll have Dr. Velasquez chime in, and then Peter, you can look at some of the other questions in the chat.
Great.
Peter, first of all, thank you for presenting to our team here. You had about 100 people on the line, and it just was really interesting, exciting, novel work. So congratulations. My questions are just two very simple ones. One is, can you speak to provider acceptance at the Mayo Clinic with regards to these kind of risk, integrated risk modeling within Epic, and do people find what have you learned along the way? We have several folks, including Tarek and Nihar Desai here, looking at the utilization of risk profiling was built in within Epic and order sets. And I'm just curious with your perspective. And the second one is maybe comments on if this is a way to safeguard institutions like ours from missing rare diseases. So, maybe others don't, but I'm sure Rachel and I are kept awake occasionally by thinking, did our system miss a Brugada out there that got EKG for pre-surgical screening, and if you applied this kind of work to kind of rare disease screening?
Great. So the first question is about clinician acceptance. We actually designed the EAGLE study in collaboration with a group of researchers at our Center for the Science of Healthcare Delivery, and that was their main interest. So we did a bunch of focus groups before starting the study. We interviewed about 30 clinicians across the practice to figure out what should go into the report and try to make a report that was going to be usable. It's interesting, I had generated these mock-ups of these sophisticated like sliding bar of what the risk and what's your previous pretest probability and the likelihood ratio, all this stuff. And that got completely rejected by the practice. They wanted green for reassuring, red for flag, and a very prescriptive order or don't order an echo. So that's what we actually deployed in the study. And then we did qualitative assessment, or the Center for Science Healthcare Delivery did, of each of these care teams to figure out what worked and what didn't work. And as you can imagine, the whole range of experience was represented in the study. We had clinicians who absolutely hated it. They felt like the AI was getting in the way of the patient-doctor relationship. They couldn't look at the ECG and tell what it was looking at. So it put them in a very awkward position of trying to tell the patient they needed an echo, but they had no idea why. And that was all very useful feedback. And then we had groups that embraced it wholeheartedly, and there were sort of these early adopters. And what's really interesting is we're doing a secondary analysis of that study now. And the early adopters had much higher diagnostic yield within the study than the skeptics. So if we just draw a line in the sand between the early adopters and skeptics, the diagnostic yield or the increased diagnosis of low EF was about 60% higher in the early adopters, and it was almost nothing in the skeptics. So the model is useful, especially if you use it, but we really have to do a bit of communication to clinicians so they understand what the purpose is, and they have to accept it, because ultimately a primary care doctor has to look at this, have confidence in it to the point that they're willing to take action. And within the healthcare system, primary care system, there a lot of clinicians are looking at this per person per month sort of average cost, and there's a lot of pressure for them not to drive up healthcare costs. And when Epic tells them to order an echocardiogram, they don't know why, and they're working very hard to keep the healthcare costs low for their patients. It's difficult. And I'll say personally, we have you guys do too, I'm sure, that little calculator for Chad's VAS score within Epic, and I can't remember the last time I relied on that, and that should be relatively simple. But the problem is our problem lists aren't full. There's lots of missing data in the chart, and you really can't rely on that. So even though there are technologies now to bring these sort of risk estimates to the point of care, we probably don't have rich enough data yet to do this universally. It's part of the reason I like the ECG, because we can get so much information from it that it doesn't rely on all that data extraction. Otherwise, you could just use ChargeAF. So a bit of a long answer. The second question was, do these technologies safeguard against the near misses? And I think that's exactly part of what we're hoping. So that first part of the talk about streamlining care, we could set the sensitivity or specificity based on, is this a can't miss diagnosis, or is this a should be included type thing? And when we first developed our models, we missed a couple complete heart block cases. And it's because it's a relatively rare diagnosis. So it doesn't think it's likely to be on an ECG, and it was reluctant to, the model was reluctant to report it. So we had to actually go in and do some tweaking and say, well, this is a can't miss. We need to be much more sensitive for this diagnosis, but we don't want this diagnosis to be overcalled, and we're going to make this one a little bit less sensitive. So it requires a lot of ongoing tuning. And you could think about a model maybe for the can't miss diagnoses as as a first pass, or for various applications. And we're trying to develop those over time.
Here, we're right at the top of the hour here. I'll let you take maybe just one more question from the chat, and then we'll wrap things up.
Well, there's a little bit about what sort of data does this, we're using raw ECG data, so we had to get it out of Muse and out of we use GE, so it's in the Muse data set. We had to get the raw data out. It may be possible to develop and apply these technologies to PDFs, but we haven't had great success with that yet. I know other groups around the country that are doing similar work have had more reassuring data around application and derivation of models using PDF data, but we probably don't have time for the rest, but I'm happy to communicate by email. It's in the chat. And thanks again for the opportunity to speak with you all today.
Thank you again, Peter. That was excellent. And I took the liberty of putting your email in the chat because there are lots of questions, and I'm sure a lot of people, including myself, will be reaching out to talk more about this. But thank you again. This was fantastic. And hopefully we'll see you in person in New Haven sometime in the near future. All right.
Great. Thank you all.
Thanks a lot, Peter. Thanks, everyone. See you next week. Bye.